Good morning, everyone. I'm really excited to be here, and thank you to the APSF for giving me the opportunity to talk. I'm at Stanford University. I'm also at the VA Palo Alto, so I hope to give you a little bit of a VA perspective. My contact information is below, so if you need to contact me, please use that. Like I said, I'm very excited to talk a little bit about augmented intelligence. Augmented intelligence is about using AI tools to help clinicians. And really, with the advent of AI and increasing use of AI within medicine, is how can we start to use these tools to help clinician decision making? This is all the more important, given the context of the opioid crisis. As we all know, there's a big human cost for the opioid crisis. As we heard yesterday, there's also a big economic and healthcare costs with ER admissions, with prolonged care of stay, and obviously adverse outcomes. I hope to talk to you a little bit about the current state of the opioid epidemic, a little bit about what I see are some of the gaps related to opioid risk management and potential and what augmented intelligence is and what it could be, and ways that and again looking more to the future as to how augmented intelligence, or how we should be thinking about augmented intelligence, can help manage opioid risks. I have no conflicts of interest that could affect the content of my presentation. My views here are not necessarily those of the Veterans Health Administration. Here are my sources of funding. I'd like you to take away three key takeaways. Certainly, what are some of the potential gaps in opioid risk management? What is augmented intelligence, and what are the ways that augmented intelligence could help in managing opioid risk harms? The first, in terms of the gaps, are really a lack of comprehensive risk assessment tools that can incorporate all of the data streams that we are currently having and that we will have. Things such as certainly the EHR, but information from public health sources, from genomic data, metabolomic data, immunologic data, microbiomic data, wearables. How can all of those data streams be incorporated to provide a comprehensive picture for our patients? And also, another key kind of gap is really around at the perioperative period. Physicians and anesthesia providers are, I think, really overwhelmed with the amount of information that we're currently having to manage, and these data streams are actually going to increase over time. And how can we then take that information, have it integrated, and actually apply it and customize it for really precision level care for our patients? To help address these gaps, augmented intelligence is really about using AI tools and helping to really enhance human capabilities. And I would suggest again looking to kind of very much to the future, ways that augmented intelligence can help with addressing these gaps is enhanced predictive analytics at the individual level, real-time population level management, and reduced cognitive load for our healthcare providers. Three, I think, points to set the stage for this presentation, which is really in the first graph to your left there, you're seeing a kind of ongoing data from Health and Human Services about the ongoing trends in drug overdose death. What you can see clearly here, and again, this is data that's, I think, known to everyone, which is that the opioid epidemic is continuing unabated, with significant increases in drug overdoses related to synthetic opioids, psychostimulants, cocaine, prescription opioids still, and heroin. At the same time, in this study from University of Michigan, we're seeing opioid prescribing by surgeons. And again, this is a retrospective study that looked at prescribing by surgeons. You can see a decrease in the number of prescriptions. But what's interesting and what they found was that the number of pills still continues to stay relatively high and potentially disproportionate to what patients need. And in terms of the third point, I think certainly this is that there's a differential overdose risk after hospital discharge. This is a study from our team where we looked at doing a national VA study of about 64,000 patients. And what we found was that the incidence of overdose was about 11-fold greater within the first 30 days after hospital discharge than in the rest of the year after hospital discharge. So in really indicating that we have a period in which we can intervene, and how can augmented intelligence really play a role in that. What are some traditional ways that we've been managing opioid risk? There are four really: prescription drug monitoring programs, opioid contracts, patient education, and the use of multimodal analgesia. PDMPs are really widely used. And they've started to make a difference, and data show that they have about an 8 to 12% decrease in risky, so-called risky prescriptions. But there's some challenges in using PDMPs, and the fact that data sharing between states is often incomplete, that data can be that they're not being accessed as the way that they need to be. Opioid contracts, they are very useful in helping manage opioid prescription use by patients, but that can be perceived as being potentially coercive and are sometimes lead to challenging discussions about how patients should be managing their opioid medications. Obviously, patient education is an important and ongoing role for how best to manage opioids and potentially ways to talk about opioid use, wasting, and really also about the role for disposal within the community. And finally, the use of multimodal analgesia. Multimodal analgesia has been shown to really is just, again, non-opioid analgesics has been shown to decrease opioid use anywhere from up to about 30% of, whether it's in the hospital or out of the hospital potentially. So it's an ongoing important tool in our management strategies. But what are some of these gaps? And I would suggest there are like really two gaps. Two sets of gaps, rather, as we mentioned: comprehensive risk assessment tools that really take all of those information data streams that we have available now, that really look at the preoperative period and look at patients' history of substance use, their past social history, where the community that they live in, their all of the kind of really biological data streams such as genomics and metabolomic data, and really their combined picture, and really say, can we actually put this together to provide a comprehensive risk assessment for our particular patient as opposed to a population level average assessment. And another, certainly, I think, gap would be around perioperative information overload. I think as healthcare providers in general, we're subjected to so much data that the act of trying to kind of take and integrate all this information and apply it to the patient that we have, particularly around surgery, can often be challenging and leads to, I think, difficulties in really customizing to the particular patient's needs at hand. With that, I think there is that, certainly as we look to potentially AI tools, I think it's important to kind of think about Moravec's paradox. And Hans Moravec is a computer scientist at Carnegie Mellon University. And he noted a while ago that machines and humans really have opposite strengths and weaknesses. Computers are really very strong at reasoning, at handling large volumes of data and doing it very quickly. Humans, on the other hand, are adept at the obviously it's sensory motor kind of needs of being able to pick a particular screw out of a set of tools here, and really being able to obviously provide that kind of empathetic care to patients that patients need. So really, an opposite set of strengths and weaknesses, and things that can be kind of, as we look to incorporate AI tools, how can we then take advantages of these strengths and weaknesses to provide certainly an approach that incorporates both. And this is certainly, I think a statement from the AMA, and they kind of really came up with this idea of augmented intelligence. This is how I think many clinicians view the development and use of AI tools, which is a conceptualization of AI that focuses on AI's assistive role, emphasizing its design to enhance human intelligence rather than replace it. And I think we all want, AI to kind of really assist us in taking better care of our patients. And I think part of this is ensuring that humans are in the decision loop as opposed to being replaced. With that said, this approach has started and really kind of, and it kind of started especially with the COVID pandemic. But I think, and I saw this headline, but I think it goes to the point that during the COVID pandemic, hundreds of AI tools were built to catch COVID, but really none of them helped. And I think there were severe limitations. And I think one of the key limitations were that clinicians were not involved in the development. There was a lack of really good external data as these tools were being quickly deployed and trying to be used. And a real lack of understanding of the kind of healthcare needs and environment. So with that said, I think some substantial progress has been made, which is that in many ways, augmented intelligence is already here. We have already, the use of various what are called large language models or generative AI, such as ChatGPT, Gemini, Claude, or Perplexity. Just as a quick show of hands, how many have used something like ChatGPT over the past year? So quite a few people. So I think, and again, I think the reason why I mentioned this is because I think the ability to have conversations and have tools that you can interact with is really the model of, I think, this idea of augmented intelligence. And so how can we start to apply that to the other spheres, and particularly to managing opioid risks? So I think there are really, three potential ways. And the first way is, I think, really predict better and comprehensive predictive analytics at the individual level. This is an example, and this is a paper from Journal of Biomedical Informatics. They used Cerner's entire EHR to look and predict patients who were at opioid use risk. And what they did is they used a form of what's called it's a deep learning model. They used what was called a type of recurrent neural network called long short-term memory modeling, which is looking at patterns of outcomes over time, looking at really essentially a time series, as you can see. And what they found was that, and if you look on the right side, was that, and they tried a variety of models, and with the type of long short-term memory model, they found like an area under the curve around 0.89. But the larger point is that these models are starting to become developed, and this is just using one data stream. And I think as over time comes, additional data streams will start to become available and be incorporated into these models, and these models will become even better. Another kind of really, I think, potential use of augmented intelligence is the use of population management of opioid risk in real time. This is from the VA. It's a tool. It's called STORM. Which stands for Stratification Tool for Opioid Risk Management. It's a web-based tool that combines, and it may be a little bit harder to see it, but it's a dashboard that's available for all patients. This is a model that is run in for millions of patients every night to update their incremental risk for various adverse opioid outcomes. And it looks at their current current medication regimen, various past medical history items, various interventions that have been done to project a probability for an overdose within the next year or various adverse outcomes. But I think what it serves to illustrate is that these tools, and as you can see, some of the other tools that were kind of illustrated, that were mentioned here, is that these tools will allow us to manage populations in real time, and they will only get better. And finally, I think that there's an opportunity for augmented intelligence to reduce cognitive load for providers, and that they can really help in terms of patient management with real-time assistance and monitoring. If you take a scenario, say a patient who's scheduled for, say, something like a laparoscopic cholecystectomy, who's critically ill with a history of sepsis, and has a history of chronic opioid use. And again, this is kind of looking more towards the future. This isn't there now, but you can imagine a situation where the anesthesia provider decides to use a large language model assisted management system that's to help manage the patient during the procedure. At the start of the procedure, the patient's preoperative vital signs and data are all inputted, and the large language model then generates a potential plan that one can be to help kind of really help throughout the induction phase and throughout the postoperative phase. During that induction, the LLM decides and helps, not decides, but really suggests, and I would say that's probably a better way to say it, suggests an induction regimen, but that helps also kind of modify it on the fly with the various, certain infusions that have been shown to improve various outcomes. During the maintenance phase, the LLM can really suggest various interventions, various additional medications to help improve and decrease the risks associated with opioids. And throughout either in the recovery room or the ICU, the patient suggests various, again, medications, either they're multimodal combinations that have been shown to work in this patient population to really improve those long-term outcomes. So with that, I think in a quick summary, certainly, that augmented intelligence is really a way of thinking about AI tools to help with clinician decision-making. It can help manage some of the gaps related to opioid risk management around comprehensive risk assessment, and also around perioperative kind of really information overload by enhancing predictive analytics at the individual level, at the population level, and certainly I think potentially reducing cognitive load while we take care of our patients. So thank you for your attention and your time.